Hello ladies and gentlemen, my name is Margaret Clark. I'm the Director of Home Therapies for Fresenius Medical Care South Asia Pacific. I'm going to be talking about designing the PD prescription. We're going to look briefly at the KDOQI guidelines, factors affecting clearance, some tips and pointers for designing a prescription, and then how to maximise clearances. So all our patients are individuals. This is John. He's age 73. He weighs 58 kilos. His residual renal function is 4.3 mils per minute. He ultrafiltrates 360 mils a day, and his Kt/V urea is 1.8. So because our patients are individuals, we need to have an idea of what their age and weight and height, residual renal function, their membrane type, ultrafiltration, and we need to measure their Kt/V urea. So what are we looking for when we're aiming for adequate dialysis? Well, adequate dialysis is a fully functional individual. We've got to be careful we don't just look at the lab results. We need to look at the patient as a whole. We need to consider fluid balance, acid-base balance, anemia management, bone mineral control and blood pressure control. And mostly, and more importantly, we need to preserve the residual renal function and their peritoneal membrane. Consider the mode of dialysis carefully and provide regular assessment. So deterioration of clinical and biochemical parameters can be caused by an inappropriate PD regime. And this, can happen particularly when the peritoneal membrane changes. So when these problems arise, we need to reevaluate the peritoneal membrane characteristics and adapt the prescription accordingly. So first of all, I like to look at the KDOQI guidelines because it gives a nice succinct definition of adequacy. The KDOQI guidelines come from Australia and New Zealand. So PD adequacy should include clinical assessment of well-being, physical measurements, small solute clearance, fluid removal, and impact of treatment on the individual's life. The KDOQI guidelines recommend that the Kt/V target per week should be greater than or equal to 1.7, while the European best practice guidelines recommend that if the patient is on NIPD, that the creatinine clearance be equal to or greater than 45 litres per week. So what are the factors affecting clearance? So these are what I consider non-prescription factors. They're factors that we don't have a lot of control over. So that's the peritoneal membrane transport status, which is looking at the diffusive capacity of the membrane, residual renal function, and the patient's body surface area, their weight and height. So the factors that we can have control over are things like the dwell times, the amount of volume we infuse into the patient, the number of exchanges performed in a day, and the percent glucose prescribed. So we need to aim for at least 800 mils a day of ultrafiltration of the patient's anuric. We can manage the percent glucose, although we try to encourage to use mainly 1.5% glucose, but sometimes in order to remove extra fluid we need to use a more hypertonic glucose. The modality is important, whether we choose CAPD or APD, and we need to make sure that we have a good functioning catheter, because this can compromise adequacy of the patient if the patient is not draining out properly. So when designing a prescription, KDOQI recommends that if the patient is not thriving, to increase the dialysis dose, that if they don't have residual renal function, to use a continuous prescription throughout the 24 hours to maximise clearance, and that when you're measuring the clearances in a patient, so things like the PET or solute clearance, you should do it when the patient is clinically stable, and that means at least 1 month after resolution of an episode of peritonitis. For new patients, I normally wait 4 to 6 weeks after starting PD. They recommend more frequent measurements of KT over V or residual renal function if it's clinically indicated. Normally, most hospitals measure residual renal function every 3 months. And then lastly, we need to preserve residual renal function. Residual renal function is very important in PD. Use of ACE inhibitors, angiotensin receptor blockers, and avoid things like, radiocontrast dyes when possible. So things to consider when designing the prescription are the body surface area, residual renal function, the membrane type, catheter function, and compliance. So when measuring residual renal function, I get the patient to collect all their urine for 24 hours. For the membrane, we perform a PET test, and that tells us what type of transporter status they are. For catheter function, I infuse 2 litres into the patient, and then I time how long it takes them to drain out. The drain time should not exceed 30 minutes. If it does, it means there's something wrong and you need to investigate it. Compliance is very important. So you need to stress to the patient the importance of performing their exchanges regularly, and sometimes it's even necessary to perform a home visit to look at the home situation. And then the patient's body surface area, we calculate that with the weight and height. Now, as a rule of thumb for Asian patients, I normally prescribe 1.2 to 1.5 litres per metre squared body surface area. So this is the PET graph, which you're probably all familiar with, by Twardowski. So it looks at how fast solutes move across the membrane. So we have basically 4 types of membranes: high transporters, high average, low average, and low. And the high transporters, they have a very leaky peritoneal membrane, and this means the glucose will diffuse from the peritoneal cavity into the capillaries quite quickly, and it means that the osmotic gradient will be equalized more quickly. On the flip side of the coin, our low transporters, they have a tighter peritoneal membrane. This means that the glucose will diffuse from the peritoneal cavity into the capillaries more slowly, and it means that the osmotic gradient is maintained for a longer period of time. So, what are the implications of the PET? This means that the high transporters need short dwells because their problem is fluid reabsorption. And for low transporters, they need a longer dwell and a higher exchange infusion volume because their problem is achieving adequate solute clearance. And these issues may be not apparent until the residual function is lost, renal function is lost. So this graph is showing you the different types of membranes and how you can optimize the dwell time. So you can see the high transporters in the black shaded squares. You can see that they're optimized at about 120 minutes, whereas a low transporter is optimized at 240 minutes. So this is why you need to vary the dwell time depending on the type of membrane. So for a high transporter, they have poor ultrafiltration but very good solute clearance. So with these patients, you can have CAPD with a dry night. So this means you can do the bag exchanges at 6 a.m, 10 a.m, 2 p.m, 6 p.m, and then at 10 p.m. we get the patient to drain out before they go to bed. Or they can go on to a cycler and do NIPD and then have a dry day. The high average patients have good solute clearances and adequate to inadequate ultrafiltration. And again, these patients often need a dry day if they're on the cycler, or CAPD, they can have a dry night. And then the lower average patients have good ultrafiltration and adequate solute clearance, so they do okay on CAPD, or they can have CCPD, which is they're on the cycler with a wet day. And then the low transporters have very good ultrafiltration but often inadequate solute clearance, so they need high fill volumes, so they do very well on CAPD. If they do go on to a cycler, they usually need 2 daytime exchanges to achieve adequate solute clearance. So how do we maintain clearance in our patients? We need to maximise their time on PD. So for some patients, this may be increasing the dwell time. We may need to maximise the concentration gradient. So in some patients, this may be optimising the dwell time, so the dwell may need to be shorter, particularly high transporters, more frequent exchanges. And to maximise the peritoneal surface area, we need to have larger dwell volumes in order to recruit all the pores. And then if we need to increase ultrafiltration, we may need to use a higher glucose concentration, especially for the long dwell. Now, some of the prescription traps can be things like non-compliance. So if the patient is not doing their exchanges evenly or as prescribed 4 times a day, or if they're reducing the dwell volumes. I had one patient that used to flush for 3 minutes, and most of the solution went into the drain bag. The other thing is, if they lose their residual renal function, that will often cause problems as well, so you need to keep an eye on that. More things are inappropriate moves from CAPD to APD. This is particularly pertinent to your low transporters. Often they don't have adequate solute clearance on a cycler, so you need to watch that. Or anatomical abnormalities such as hernias and leaks because they're not draining the fluid correctly, or inadequate attention to fluid removal. So in conclusion, we need to design the prescription to ensure that adequacy guidelines are met, ensure that we have adequate fluid removal, that the prescription suits the patient's lifestyle, and you need to reassess your patient on a regular basis to ensure that the prescription is adequate, that the therapy meets the individual needs of the patient. And remember to preserve your patient's residual renal function and preserve the peritoneal membrane function. Thank you very much.